Lung cancer, the main thing is to establish the right diagnosis. Okay, you can't move forward without having diagnosis. And once you have a diagnosis, the backbone of what direction are you taking is the staging. So without the proper diagnosis, the proper staging, you can be treated in the wrong way. An early stage can be mistaken as a more advanced stage and needs a window of surgery, or a advanced stage will be diagnosed as an early stage and get surgery, with surgery in that particular case will not change the outcome in the management. So the primary therapy for early stage disease remains surgery. Stage 1, as it is a primary therapy for early stage lung cancer, even though it should say that radiation is moving at a very fast pace, and the CyberKnife is having excellent outcomes. So for people that is not surgical candidates for stage 1, they're having very good outcomes so far, and that data is coming out very promising. And also palliative therapy for advanced disease, sometimes surgery has a role. To have the proper staging, you have to have most of the time a biopsy of the mediastinal lymph nodes, and that's the main step of staging. So it's important to have the staging to see if you're early or advanced stage, guides the therapy, and helps you to get into the proper treatment line. So how you do the staging, and that also applies for diagnosis. So chest X-ray, chest CT, PET scans, and once you have the radiographic staging, which is a clinical stage, then you need confirmation by pathology, and that's where the endobronchial ultrasound and the mediastinoscopy significantly plays a role. So in terms of diagnosis and staging, here you have all the modalities that are being used. Most common though in the ER and even the primary care setting is a chest X-ray. The downside with the X-ray is that there is small lesions that will not be detected by a chest X-ray. So the chest X-ray can be read as normal if you have a very small lesion. And that's why we recently got, well, not recently, but over the last few years, we have the CT screening program moving forward. First, insurance companies approve it, and most recently, CMS approved it. So even Medicare will cover screening CT scans. And if you fall into, that's very important to make a parenthesis, if you fall into the criteria to have a CT scan based on age and risk factors, even if you don't have any insurance, if you have access to places like before, you can get it done for $99. I mean, it's a no-brainer here in the risk group not to have it done. You have all the tests like chest MRI, PET scan, and brain MR. All that can be used in diagnosis and as well as in staging. Back years back, you could tell that mediastinal staging was mainly done by mediastinoscopy. Still, it's very common, but now with the endobronchial ultrasound and most recently with the navigational bronchoscopy system, you don't need to do an invasive operation to diagnose those lymph nodes. And the success rate of endobronchial ultrasound is greater, it's in the 90%, 95+%. Navigational bronchoscopy now is actually in the third generation in terms of the equipment, which we recently update our equipment to the latest, and it's a very good technique, very promising, and actually for diagnosis will be probably replace the CT-guided biopsies as the technology is used more often. The navigation of bronchoscopy is a very nice technology in which you have the bronchoscope, as you see in the picture, and then you have a sensor at the tip. So you place a patient on an electromagnetic mat, and that's why the name is electromagnetic navigation bronchoscopy. And then you do a CT scan, and you upload that in the system, and the software can tell you like a GPS where to go. And you can find very peripheral lesions using that technology combined with fluoroscopy and do biopsies. And not only that, you can use it for staging in lymph nodes, and you can use it to drop fiducial markers. And the complication rate of dropping a fiducial marker CT guided is higher than with the bronchoscopy. So the risk of pneumothorax could be as high as 15–20% in bad COPD patients, and with the navigation proctoscopy, it's like 2–3%. So that's a significant improvement. So it can be done for biopsy of lung nodules, as I said, for fiducial markers, so they can do CyberKnife for brachytherapy, which is kind of falling off. It's not that successful as was thought in the past. And can be done for tattooing. So if you have a lesion that is too small, sometimes when you do the VATS approach, the video-assisted thoracoscopic approach, you cannot feel a centimeter lesion with the instruments because it's a sponge that you can't collapse that much. And sometimes you have to make a mini thoracotomy incision for those tiny incisions to your hand and feel it before you wedge it out. With this technology, you can actually find the lesion and put some methylene blue and tattoo that lesion. And when you go in with minimally invasive approach, you know by the color where the lesion is and wedge it out without opening the patient. This is how the setup is. This is a sensor board, the guide that is at the tip of the scopes in terms of equipment. And in this picture, you can see that the relationship of the anatomy. In the picture on the left side, you see the trachea, the aorta being divided and thought in a conventional way, the pulmonary artery, and then the mapping of the lymph nodes. So lung cancer staging go from stage 1 being the earliest, stage 1A, to stage 4 being the latest. And stage 1 and 2, usually you do surgery. Stage 3 and 4, you do combined radiation, chemotherapy, and chemotherapy alone, depends on what stage you are. But what tells you what stage the patient is I may have a slide to deal with this, is a TNM classification. T stands by tumor size, N by nodes, M by metastasis. So lymph nodes, and a good way to remember is lymph nodes with a single digit are usually N2, so those patients are not surgical candidate. And that's why it's so important to properly stage patients. And usually lymph nodes within the lung are 2-digit nodes, those are still making the patient surgical candidate. So how to diagnose those nodes? Once you establish the diagnosis, you have either the endoscopic ultrasound, then you can do a fine needle aspiration, or on the right side you have the endobronchial ultrasound, and the tip has the balloon is not inflatable. You can inflate that and have a ultrasound to survey the mediastinum, and you can find those nodes, and even people with nodes that are not significant CAT scan can find them with the ultrasound for the midway. And for some patients that have bigger tumors, more than 3 centimeters, we stage the mediastinum regardless of the PET scan. And we have several cases every year that has negative PET, negative CT, positive endobronchial ultrasound. And those patients benefit of chemotherapy radiation first. And this is a picture of the lymph node, the ultrasound. You can see the lymph nodes right there. And this is a picture, you see the heart, the vessels, and the airway. And the scope goes down, the windpipe is behind all those structures. You can go down to the subperitoneal space, and in real life, ultrasound the lymph node subperitoneal space and put a needle through it. You can actually see it going in. So this is a very live puncture in which you know if you're in the node. This is not like a one needle that you kind of feel where you are and then you try to do the biopsy. This is you can see the needle going into the node, and sometimes when you have a suspicious node and you hear that the pathology comes back negative, then you can angle different way, get a different section of that node until you can prove it's benign or malignant. In terms of the surgical options, once you have done the proper diagnosis and the proper staging, then you have to see if that patient is indeed a surgical candidate. So you have to do an adequate preoperative workup. And then you can see if this patient is surgical candidate or not. And there's multiple things that will dictate that. You may have a patient that has a stage 1A lung cancer, which surgery is the main treatment. The patient has bad COPD, he's obese, bad pulmonary function test, bad heart, low ejection fraction, you name it. It's a lot of comorbid conditions that will preclude the patient from having surgery. So even though the patient is a surgical candidate, you have to make sure that meets the criteria to have the operation done. Once you have done that, if the patient's in early stage lung cancer and the pulmonary function test is adequate, which, you know, when you look at pulmonary function tests, there's tons of volumes and capacity you see in that test. pretty busy couple pages, but there's only two that are very important. The FEV1, which stands for forced expiration volume in 1 second, and the DLCO, which is diffusion capacity. Those numbers are greater than 60%. That patient usually can tolerate a lobectomy. And in terms of what surgery is being done, if the cancer is confined to one lobe, you can do a lobectomy. If the cancer is bigger or extend to another lobe, or is centrally located, but there's evidence of metastatic disease, you can do a pneumonectomy, which means removing the entire lobe. In terms of the approach, you can do a minimal invasive, or you can do it open. And the minimal invasive arm will split in two approaches. You can do it robotic, or you can do it thoracoscopic, which is about the same. The robotic is 4 incisions, the thoracoscopic approach is 3 incisions, usually surgeon preference. There's no clear data of one being better than the other one. In terms of how you do it, on the right side you see how minimal invasive approach is done. It's 3 incisions. And a thoracotomy, standard thoracotomy, is a posterolateral thoracotomy between the ribs and usually inferior to the scapula level. This is, you can put the lights on for a second again, if it's possible. This is a patient, sometimes you suspect a lesion. The biopsy is not conclusive. I mean, you can clearly pre-see the lesion. I have a marker, but, oh, you didn't? Okay, you can clearly see the lesion right there. And sometimes in people that are surgical candidates, you can take them to the OR without a biopsy. And what you do is, you go inside the chest and do a diagnostic thoracoscopy. You can look at the, see the lesion is right there. So you can find the lesion pretty accurately, feel it with your instruments, and then you can wedge it out, okay? That's a right upper lobe lesion. This is the lower lobe here, this is the middle lobe here. The major fissure point here, and the vessels in the hilum are deep right there. So in patients that has a peripheral lesion, sometimes we don't do CT-guided biopsy. There's a highly suspicious lesion in a PET scan. It looks like cancer. We go ahead and we take it out. And this is a diagnostic and a therapeutic operation at the same time. So you wedge it out, and you send it for frozen section. The frozen section shows a benign lesion, then you're done, you close. If the frozen section shows that this is a malignant lesion, then you can move forward and do a lobectomy, which is way more complex than just wedging it out. It's just you have to isolate the vessels to each lobe and divide it with the airway going to that lobe, of course. So it should be probably no more than a minute more. And see, once the wedge is completed, then you can put the specimen in a bag. See, you can see the pulmonary artery right down there. That's the hilum of the lung, going to the heart. See that's completely resected now. So you can see the vessel right there beating. And you can put a bag inside, put it in, so you have any spillage in case malignant, so malignant cells. Then you take it out in a bag, and then you send it for path. You sit tight, and depends where the path is, you move forward and do a cancer operation, or you stop, and that's pretty much what you do. In terms of new things, you have the Da Vinci, which is the same type of procedure, is considered minimally invasive, but instead you're doing it with thoracoscopic instruments. You use the platform to the arms, and then you're working from a console. Okay, and that's it's a pretty good technology. I mean, it's getting more and more common, and it's looking into these, comparing these to regular thoracoscopy to see if there's any advantage. It's certainly more costly and there's more expense for the hospital, but this is being looked at. I think in the next couple of years we'll know if there's any advantage to it. So, summarizing my part here, I mean, lung cancer, first of all, is a multi-specialty approach. You need the oncologist, you need the pulmonologist, you need the radiation oncologist, thoracic surgeons, pathologists, respiratory therapists, nurses, social workers, you name it. You have to have everyone in coordination with this, because the patient needs to get into the proper line of therapy, be properly diagnosed, properly staged, and be properly treated to have a better outcome. So it's a multi-specialty team, and that's what cancer centers are doing. We're fortunate enough that we do have one here. We have this multi-specialty approach. But it's moving forward. I mean, lung cancer, we're way behind compared to colon, breast, and all the cancers, but we're getting there. The CT screening has been improved over the last couple of years that will save more life and more money than the colonoscopy and the mammogram together for breast and colon. Okay? And don't forget that lung cancer kills more people than all the other cancers combined. And one fact that I just want to emphasize is, just because last night we were in this meeting, is that people think that lung cancer is exclusively of the elderly or above 60 patients that smoke, and we have last year 30 million people young with lung cancer with non-smokers. That is more than lymphoma in the entire nation. Okay, so something to keep in mind that not only the smokers will have lung cancer, and if you have any concern or any risk, you should be checked for it. Okay.
I'm going to be mostly focusing on treatment with CyberKnife, stereotactic body radiotherapy. It almost seems like every year it's a similar talk, but I'll explain why it's such an important talk in the lung cancer field, and kind of show you some of the more recent data, emerging data, really suggesting the importance of this technology. So I figured since I'm going to be talking about CyberKnife stereotactic body radiotherapy, I should show you a picture of the actual machine itself. And within the Memorial system, the CyberKnife machine is at Memorial West. But we still treat our patients from regional. They just have to go to West to get the treatments. But this is what the CyberKnife looks like. And just by show of hands, who drives a car to work? So this is the same technology. This is a robotic arm that's actually used to assemble cars. It's just that somebody had the brilliant idea of putting a radiation machine or linear accelerator at the end of the robotic arm. And essentially, through fine, precise movements, this machine can actually deliver radiation from virtually an infinite number of beam angles and directions. And really the idea of stereotactic radiation is really just that, is to try to focus a very highly conformal and precise dose of radiation to a small tumor anywhere in the body. And so what this is it's a robotic arm, and it can move around, and I'm going to show a little video demonstration where it can come in from many different angles and treat a tumor. But some of the challenges in terms of being able to give highly focused doses of radiation to a lung nodule is the fact that when you breathe, lung nodules move. So when you breathe in, breathe out, a lung nodule will move up, move down. And unless you're able to completely track where that tumor is while the patient is breathing, you would never be able to safely deliver high doses of radiation to a small area. And so this is just a demonstration where, unfortunately, it's kind of on the side, but I'll kind of play the video again. Where this ball is supposed to represent, at the tip of this ball, there's supposed to be a little BB, and this is supposed to represent the motion of a nodule, lung nodule, as a patient's breathing. So as you can see, it can move up, it can move down, it can move in many different directions. And what this is essentially showing is that the head of the machine can actually track the position of this tumor. And so even if the patient's breathing, we put these leads on the patient's chest, and the system can actually track where the tumor is and move with it such that it's always on target. And during the course of treatment, this beam can come, the angle of this beam can come in from many different directions here. There are other units out there in the country that can give stereotactic body radiotherapy, but this is really the only one that can dynamically track a tumor. Other ones, they wind up incorporating other compressive devices to try to limit the patient's breathing so that the tumor doesn't move so much with breathing. Other devices, they kind of incorporate treating a bigger area within the lung with radiation to incorporate, to account for that uncertainty with movement and motion. Whereas with the CyberKnife, we don't do that. Since the system is able to dynamically track that, it's able to target the tumor itself and limit the amount of radiation to the normal lung, such that the patient has less side effects from the radiation. We can do the same technology and treat a tumor in the spine, and the liver, and the brain. The brain, you don't have to worry so much about organ motion. We just have the patient lie still in a fixed mass, and we're able to target the lesion directly with that. And the reason why I bring this up is that traditionally, or the early data, this technology was looked at treating patients with stage 1 lung cancer who are medically inoperable. So elderly, frail patients who typically may have multiple medical comorbidities, maybe heart disease, they've had a heart attack in the past, they've been smokers, so maybe they have emphysema or COPD, which doesn't allow them to undergo surgery to remove the cancerous nodule. And typically, the surgery that's recommended is removing an entire lobe of the lung. So the early studies looked at giving this type of radiation in those patients who couldn't undergo surgery, because the standard of care is just that, is surgery. And this graph is just to give you an idea as to kind of explains a bit the importance of this technology and the introduction of this technology. So this is a study that looked at just overall survival rates in Medicare population patients and the different ways that they were treated for their early stage lung cancer. So I'll go over what these different lines really represent. So the top line here is, this red line is those patients who undergo a lobectomy, so the standard of treatment, right? So rightfully so, these patients have the best survival. They're usually the fittest, they're able to undergo surgery, and it has a high likelihood of curing them of their early stage lung cancer. And those patients have the highest survival rate at 4 years. This green line are patients who can't quite tolerate a lobectomy, so they're not as healthy as the patients in the red line, but they can undergo a sublobar resection or just a wedge resection where they can remove a portion of the lung where the cancerous nodule is, but not removing an entire lobe of the lung. But this third line right here is really those patients who are too sick to undergo surgery, and they get treated with stereotactic body radiotherapy, much like what we do with the CyberKnife. And you can see that it's pretty much comparable to this green line, the sublobar resection. And you may think, well, it looks like it's actually worse survival. Well, bear in mind that these patients are typically sicker because you can't even undergo surgery. So if you really adjust for their comorbidities, it winds up being the same exact survival. But more importantly, I would say there's an importance to these two lines, right? This yellow line represents doing standard old traditional type radiation, where you do a daily low dose of radiation over 6 or 7 weeks, whereas with CyberKnife you only do a total of 5 treatments, so you can get the treatments in 1 week. So 1 week of treatment versus 7 weeks of treatment, and you can clearly see that the outcomes are much worse with the traditional way of doing radiation. So this speaks to the power of the technology and the importance of getting a very high dose of radiation to a small localized area to get rid of the nodule. And then this last line right here is, even in patients with stage 1 lung cancer, some of these patients traditionally we think of, they're 70, 75, they're very frail. They think, well, you have lung cancer, you have heart disease, COPD, there's not much hope for you, so why even bother doing anything? Well, if these patients do nothing, their survival is by far the worst of all the entire bunch. So this really speaks to, even if you can't do surgery, by at least doing something like CyberKnife or stereotactic body radiotherapy, you are able to make a significant impact on patient's survival just by doing this treatment. And we're talking, this is minimally invasive. Patients don't have to undergo anesthesia. There's really not much of a recovery period. And the important thing I also want to mention here is look at the survival in the first 6 months. You see this blue line juts out above the rest? These are patients actually treated with stereotactic, and within the first 6 months, their survival is actually better than the surgery arm. So this speaks to the fact that this is probably representing the fact that there is a bit of a mortality rate associated with surgery, right? So maybe 3% of those patients who undergo surgery may still die from the complications of a lobectomy. Whereas patients who undergo stereotactic radiation, really the complication rates are very low, such that if you have somebody who's very sick and frail but has an early stage lung cancer, you can still offer them this treatment and can be done safe and effectively in the short run. They probably will wind up being a little bit better off than somebody who can't, than somebody who gets the surgery with the lobectomy. This is another interesting article. This is actually a population-based article. It kind of looks fuzzy, so I kind of apologize for how it looks. But this is looking at treatment of elderly patients in a Scandinavian country with stage 1 lung cancer and looking at the trends in treatment. So they looked at a time period from 1999 to 2001. And this yellow represents the percentage of patients who underwent surgery. This blue represents patients who underwent radiation treatment, and this gray represents patients who did absolutely no treatment whatsoever for their early stage lung cancer. And then from the 1999 to 2001 period, there was a pretty high percentage of patients who decided not to undergo any sort of treatment, about 40%. And as you kind of transition to the more modern day period from 2006 to 2007, there's a larger percentage of patients who opt to proceed with treatment with radiation and less patients who decide to do nothing. And what this study shows is that on a population base, if you look at the survival rates and the outcomes of those patients, if you first look at the different time periods, these are looking at all the patients, regardless of whatever decision they make, whether it was surgery, radiation, and no treatment. But if you look at the different time periods, this gray line represents those patients who were diagnosed from 2006 to 2007. And it shows that those outcomes or the overall survival rates were significantly better in those patients who were treated at a later point in time. And the single factor that really accounted for that difference was really the introduction of stereotactic body radiotherapy, which is these patients right here. These are the patients who underwent radiation treatment in the different time frames. And as you can see, there's this clear separation in the graphs here suggesting that those patients who underwent SBRT actually had better survival outcomes because more patients decided to undergo treatment as opposed to not doing anything for their lung cancer. There's really not a difference here. These are all the patients in the different eras who underwent surgery, and there's really no difference in the graphs there. And then these are the patients who decided to do nothing for their lung cancer. And as you can see, the survival rates are relatively dismal because there was no active treatment. But I like showing this graph because it really shows the importance on a population-based scale, even in patients who are elderly, diagnosed with early stage lung cancer. By doing some active form of treatment, you can make an impact on the patient's long-term survival and quality of life. And this is just showing you kind of what the plan looks like, what a CyberKnife plan looks like. All these little blue lines represent all the different beam angles that we target the tumor in blue. And as you can see, we could have hundreds of beams targeting the treatment. And the idea, once again, is to focus the dose to where the tumor is, but also minimizing the dose to the surrounding normal tissue. So this is looking at the dose cloud around the tumor. And as you can see, we're able to give a very tightly conformal dose around the tumor and minimize the dose to the spinal cord, minimize the dose to the liver, really almost get no dose to the heart whatsoever, and try to ablate this tumor. And this is a gentleman who was in his early 80s. He couldn't undergo surgery because he had a history of coronary artery bypass graft surgery, coronary artery disease, he had pulmonary hypertension, COPD, renal failure, and he was able to undergo this treatment without any significant side effects. And this is just kind of showing the before and after on the PET scan. This is before the treatment, where you could clearly see the nodule, and it was have it on the PET scan. This white mark is a fiducial marker that was inserted so that the system can track the tumor. And as you can see, the lesion completely resolved. Now you could say, what's all this little fuzziness here? You know, after the treatment, there could be some inflammation in the lung bases that manifests itself with this kind of hazy appearance in the lung, but the key thing to focus on is that there's really no activity whatsoever, and the tumor pretty much dissipated. Now there's more and more clinical trials looking at, phase 2 trials looking at implementing this technology and treating patients who even have metastatic lung cancer. So the idea is, the traditional thinking is you have stage 4 lung cancer, all you need is, the only treatment option available is chemo, 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 and there's nothing else that can be done. But there are now more and more studies suggesting that in patients who have very few metastatic deposits, maybe incorporating this type of treatment to those metastatic nodules or lesions. And the idea is maybe by treating those and getting rid of those tumors, maybe those patients can live longer and they can continue on chemotherapy for longer. And maybe there can be an improvement in overall survival. Now, it still needs to be tested in phase 3 trials, but the emerging phase 2 data seems to suggest that this treatment strategy of patients with very localized metastatic disease and treating them with either surgical resection of a localized metastatic deposit, or CyberKnife, or SBRT, or maybe even doing radiofrequency ablation, that you could make an impact in terms of improving their survival. And once again, this is kind of fuzzy, but what this is showing is that progression-free survival, so the time from patients getting treatment with the radiation and them failing, in other words, another tumor popping up, is 14 months. And this is rather impressive, because in those patients where maybe they only have 3, 4, or 5 metastatic lesions, if you treat all those lesions with SBRT, typically you're thinking of a progression-free survival on the order of maybe 6 months, maybe 9 months, but here you're looking at 14 months, almost doubling at that time. And they can continue on their systemic therapy, whether it be Tarceva or chemotherapy, and you're still able to keep the disease under control for a longer period of time. And then in addition to that, if you look at the survival rates, you're looking at a median survival rate of 20 months. Traditionally, you think of lung cancer, stage 4, median survival rates of maybe 6 months. Now we're probably pushing it closer to 12 months. Here in this patient population, you're able to get up to about 20 months survival by implementing this treatment strategy. Once again, it still needs to be validated with phase 3 randomized data, but I think we're slowly moving the needle along in terms of improving survival rates in our lung cancer patients. And a lot of it has to do with improvements in chemotherapy, but I think part of it is also the improvements in the delivery of radiation treatment for some of these patients. This is an abstract looking at this same treatment philosophy of doing highly localized radiation for patients who have metastatic disease. And once again, this kind of looks a little bit fuzzy, but the key thing here to keep a focus on is the fact that you can actually control those lesions. There's over 90% likelihood of completely destroying that tumor at the 1-year mark. The control rates fall down a little bit to 80% at 2 years, but that suggests that this treatment is highly effective in really killing that tumor and really trying to improve the control rates and keep the patients on their active systemic therapy and really prolonging survival. And then this graph here is just showing the control rates for different lung cancer types. Here the blue is lung cancer, that's still about 70% long-term control rates. And then this is just looking at the survival rates. And with this treatment strategy, you're still looking at median survival rates of about 26 months by incorporating aggressive local treatment in those patients who have metastatic disease. And once again, you traditionally think of median survival rates of maybe 1 year, 12 months, maybe 18 months, but this is kind of pushing it up to about 26 months. And here in the non-small cell lung cancer patients, it's 26 months. So you're looking at about 2 years median survival, suggesting that you can offer effective local therapy, and that could impact the patient's overall long-term survival. And this is just showing you what a CyberKnife plan looks like if you were to treat a patient with tumors in the liver. So you can target the tumor in the liver, and you can probably see it better on the PET scan. We can fuse PET images and target pretty much any sort of tumor anywhere in the body. There's now, but kind of in the same vein of doing local treatment for patients with metastatic disease, same theory goes with small cell lung cancer, right? If you have metastatic small cell lung cancer, the thinking is you just do chemo, you just do chemo, you just do more chemo, and there's no role for radiation. Well, they did a study, a phase 3 study in Europe, and this is the name of the study. It's the International Multicenter Randomized Study on Thoracic Radiotherapy and Extensive Stage Small Cell Lung Cancer Patterns of Disease Recurrence. And what this study showed that is if, even though the difference may seem relatively small, if you look at overall survival, if you give patients chemotherapy, they respond well to chemotherapy, and then you give radiation to the primary lung cancer in the chest, you can actually improve their long-term overall survival. Now, this difference may not seem like a lot, but there's actually a 10% difference at 2 years. So maybe 1 in 10 patients, you could be doing a lot of good by implementing this treatment. And once again, this treatment, you can deliver it with relatively minimal side effects and probably just do it over the course of 2 weeks. This is showing the progression-free survival. And then the key thing that I would want to focus here is in those patients who don't get radiation, right, they're more likely to relapse within the chest, right, because you're not giving them any additional local therapy, you're just giving them the chemotherapy. Whereas those patients who did get the thoracic radiation, you find that the relapses tend to be not in the chest, but in other sites. So that seems to be the theory behind as to why they may be surviving a little bit longer, which is you're keeping the disease in the chest better controlled, and the burden of the disease is probably less, such that they can actually live longer. The key thing to also note is traditionally, whenever you have a patient with lung cancer with brain mets, the traditional thinking is that you would have to treat the whole brain because the whole brain would be at risk of having a metastasis. But we now know that in patients who have 1, 2, or maybe 3 tumors, metastatic tumors in the brain, you can consider just doing localized radiation and avoid the whole brain radiation. And you find that it doesn't really cause any change in survival rates if you compare it to somebody who did get whole brain radiation. And the reason why we try to avoid the whole brain radiation is that this graph is just showing quality of life measures. And the lower the numbers are, or the lower on the graph here, the worse the quality of life is. And this blue line are those patients who get whole brain radiation as opposed to those patients who only get either surgery or stereotactic radiation. And what you find is that overall, patients' quality of life diminishes by doing whole brain radiation. So if you're able to just do localized treatment to the tumors in the brain, you're actually able to not cause a detriment in their survival, but also not affect the quality of life as much as compared to those patients who get whole brain radiation. And once again, this is just showing you a plan of localizing the radiation to where the tumor is within the brain. And this is just kind of showing you a before and after, where you can clearly see the nodule here in the brain, and then immediately after, there's, you could have some post-treatment enhancement in on the MRI, but this suggested that there was a good response to the CyberKnife treatment.
So every 4 minutes, a patient will die of lung cancer. Okay? Lung cancer will kill 4 times more patients than prostate, pancreas, breast, and colon combined. Okay? And yet, the money that's allocated to lung cancer research is only 1/4 of any one of them. Despite that, the survival for stage 4 lung cancer has gotten better, but not as good as any of the other 4 tumors that you see in that table. So about 90,000 new metastatic cases in 2013, and about 160,000 deaths in 2012, with a 5-year survival rate in the 16% overall, and only 4% for those patients with advanced stage. So when we talk about lung cancer, we are mainly going to be talking about these 2 guys right here, adenocarcinoma and squamous cell carcinoma. They comprise about 70% of all lung cancer cases. Those are the non-small cell lung cancer, which I'm sure you heard about today. And then 10 to 50% small cell lung cancer, which is a different disease altogether. So how about screening? Is there something that we can do in subjects, in people that are at a high risk for developing lung cancer? So for quite a long time, people were advocating for CAT scan. So get a CAT scan every year, see if there's something that we can find earlier on so that you can operate, send the patient to Dr. Black and Dr. Tarazzi. So right up here, 60% of patients are diagnosed after the disease has spread. So that's definitely not good. The 5-year survival rate is anywhere from 3 to 4%. However, if you detect it early, so stage 1, 2, and after stage 3, you can change that to about a 50 to 70% depending on which stage. The earlier the stage, the better the survival. The NLST trial is a trial that was done in America with roughly 55,000 people getting a low-dose CT screening. It's important that it's not a regular CT of the chest, because you get a lot more radiation with those. Okay? So it's a low-dose CT scan that has to be done, must be done at a place where they know what they're doing. This is not the CAT scan place that's near Walmart, or but you know what I'm saying. It's got to be a reputable place, right? So you get a CAT scan. Let's say that your CAT scan was negative, or they saw just a tiny little nodule. You get a CAT scan for another year, right? And then subsequent follow-ups over 6 years for patients that are high risk. So people that are 55 to 75 years of age with a smoking history equivalent of 1 pack for 30 years are considered high risk. So based on the results of this trial, right, 50,000 people, the US Preventative Task Force, so those are the guys that basically said colonoscopy is good, mammogram is good. So they said, you know what, CT screening for lung cancer is good. Let's go ahead and do it. So soon after that, the private insurance said, we're going to pay for it. Memorial being one of the first in the country, by the way. Okay, so each and every one of us, if we qualify, we'll get that paid. The problem is that a lot of the private insurers, they follow what Medicare and Medicaid said. CMS said that they will pay for it starting next year. So basically, as of January of 2015, this is going to be paid for everybody. So how about people that smoke less than the equivalent of a pack for 30 years? How about those with secondhand smoking? How about those that smoke marijuana, right? How about those with radon gas exposure, for example, another high-risk feature for developing lung cancer? Unfortunately, those that are in the moderate or low risk, we do not have data to support that. However, if you do want to be screened, and you are in that high risk, however, with less smoking or secondhand smoking or radon exposure or asbestos exposure, you'll be paid for. So let's move on to someone that actually is diagnosed with lung cancer. How does lung cancer present? So it's very non-specific, right? You don't feel right, you lose weight, you start coughing. It'll be pretty more obvious if you start coughing up blood. But basically, it's very non-specific, and therefore part of the reason why people present late. Neglect is a very powerful thing. You lose weight, you say, not too bad, I'm losing weight, and yet I'm eating like a pig, right? So basically, people will present with non-specific symptoms. You have to have a biopsy, and up until 6-7 years ago, it was a one-size-fits-all approach, even taking into account that pie that I showed you, that adenocarcinoma, squamous cell carcinoma, it didn't make a difference, right? And then we started looking more into, well, does it really make a difference whether it's one histology versus the other? And the answer is yes, and I'll tell you a little bit more about that. So this is the algorithm for advanced non-small cell lung cancer in this day and age. So tissue diagnosis, you take into account whether the patient has a good performance status or not, and histology, whether it's a squamous cell carcinoma, non-squamous, largely speaking adenocarcinomas, right? And it matters because you treat the patients differently. The chemotherapies are different, whether you do not have these molecular changes. So we now know that there are certain drivers for cancer growth that we can do something about. So it's like having that key to unlock that specific keyhole and say, you know what, this way I can stop the way that cancer grows in a much smarter way than a one-size-fits-all poison approach, which is basically chemo, right? So if you were to look at this 10 years ago, this whole thing, down here would not exist. It's basically, can you take chemo? Yes, no. That's about it. So we have a 46-year-old woman that has persistent cough. She's not coughing up blood. She smoked a pack a day for 10 years, like quit 18 years ago, and her performance status, meaning what is she able to do and how good is she, it's actually pretty decent. She gets a little tired, but that's about it. She gets a PET CT scan, and there's large mass down here. Okay. And there's evidence of metastasis in the lung, in the other lung, right here, and in the bones, as you see here. So she gets a biopsy of that mass, and that mass tells us that she's got a non-small cell lung cancer, and that's about it. That's as much as the pathologists can say. So they do further studies, and they say, well, it looks as if it's an adenocarcinoma. So the patient sees a thoracic oncologist, and that oncologist says, hold on a second, tell me more about it. Is there any mutation of those molecular studies, those driver mutations that I was telling you guys about? So the patient is found to have an endothelial growth factor receptor mutation. So it's basically like knowing what makes that cancer grow, right? She gets an MRI of the brain, which is negative, right? So now the question is this patient going to get chemo, yes or no? Any wild guess, anyone? Chemo, no chemo? So the good thing is that by patients having these mutations, we can spare them from chemotherapy. Patients can take actually a pill. Okay. Now, don't think that it's like taking an aspirin that you actually feel a whole lot better and then, no side effects. This stuff is powerful, and we have endothelial growth factor receptors in a lot of places, including the skin, and that's why patients get a pretty significant rash, like acne. Okay, they get bad diarrhea because we got a lot of those receptors in our gut. Okay, but it's a lot better than chemo. Okay, and it's a pill, and you do it at home, and you need to come to the office as often as other patients. So basically, we treat patients with that pill based on this study. This was the first study that showed that a therapy for that particular mutation is effective. So it was actually compared to what the standard of care chemo. So in red is that pill called gefitinib, or Iressa, which is mostly used in Europe and Asia, not in the US. Okay. So for those patients with that mutation, patients do better on gefitinib than chemo. And the opposite is also true. Patients without the mutation do worse on the pill than they do on chemo. Right? So you must have that mutation in order for the pill to work. So is there any other mutation that we can check for? The answer is yes. This mutation is called ALK, or anaplastic lymphoma kinase mutation. It's a mutation that was, as the name implies, known in lymphomas. It was discovered in 2007 in lung cancer cases. So they actually started to look for a medicine to target that specific mutation. Now, this is only present in 1% of adenocarcinomas. So remember, let's go back to that pie. You take 100% of lung cancer cases, right? Let's say 40% or so would be adenocarcinomas, 1% would have that mutation. Okay. It's unusual enough that in a year, just this past week, I had 2 of those. By the way, the first 2 with me here in the morning. So patients that have that mutation can be treated with that medicine called crizotinib that does the same thing, targets that specific keyhole, right? And unlocks that mechanism, basically stopping the promotion of cancer growth. And patients do remarkably well with very few side effects. For this particular medication, crizotinib, the main issue side effect-wise is fluid retention. That's about it. So I told you about skin rash. As you see, there's a nice chart just because it's present in most patients that will take this medicine. So what's the take-home message of my talk? So we need tissue biopsy for histologic subtyping. We don't treat everybody the same. It matters what type of cancer you have. You have to have testing for EGFR mutation and ALK fusion gene mutation, critical in making treatment decisions, and we actually will wait to have those mutations back before we put someone on chemo, unless it's an emergency. Okay? Testing should be concurrent, and again, what I said, completed in less than 2 weeks to ensure that we put someone on the medicines that they should be put on, and not a one-size-fits-all approach. And for patients that have any of those mutations, standard of care is molecular-based therapy. The position of the International Association for the Fight Against Lung Cancer, ISLC, is that e-cigarettes are just as bad as cigarettes, so not good. My position is I would not smoke anything coming from China that has some electricity or something that can blow up in my face. With marijuana, there's not a whole lot of research done, as I'm sure you guys would understand. There is some medicinal value to it when it comes to the risk of lung cancer. Any smoke inhalation would actually be detrimental.